where your fat weight is about 20% of your total body weight. If you were going to have the same amount of energy and store it as hydrated glycogen, that 160-pound individual would weigh 220 pounds. So gives you an idea of, obviously, the caloric value of fat is significantly greater, of course, than carbohydrate. So what are the sources of fatty acids in the body? Obviously, a diet. And these dietary lipids are processed by the intestinal cells with the release of chylomicrons into the lymphatics. Then newly synthesized lipids, again, these are newly synthesized from carbohydrate, from glucose, and mostly by the liver. And then when needed, we can mobilize lipids from our adipocyte stores. I always tell people who want to exercise a lot, and Bryce, you were talking about one of your patients getting an exercise equipment. When is the best time to exercise? Always first thing in the morning, because we fasted overnight. We're already primed to work on lipid. And since you're fasting, the only lipid that's available to you is from your adipocyte stores. So that's why it's always better to exercise in the morning. Just an interesting aside, one of these days I can give you my lecture on sports nutrition if you care to listen to me drone on about that.
That sounds like
So,
it'd be interesting, yeah.
yeah, we can do that towards the end of the year. So when we go from the fed state to the fasting state, we have a number of metabolic changes. Glucose is formed from glycogenolysis, and muscle mass is preserved. We always want to preserve muscle mass whenever possible. Fat from adipocytes is oxidized to form ketones, which then are used for energy. And during prolonged fasting, the body relies on fat conversion to ketones as the primary source of energy. So here's a typical diagram that shows you on the x-axis the time after eating, and then the source of energy is shown on the y-axis. We start with food, then we go to glycogen. When our glycogen reserves start to be exhausted, we start to use our muscle gluconeogenesis. When that starts to be exhausted, we're turning to heart muscle and other cells. For example, intestinal cells under starvation will atrophy. The intestinal wall will atrophy by as much as 50%. And then, of course, when this starts happening, when we start to break down muscle and other sources of body protein, we then engage in fatty acid oxidation. And of course, the fatty acid oxidation hopefully spares the muscle and a cellular protein. So all dietary fat and body fat stores are long chain in length. We do not store medium chain triglycerides. All of our dietary fat is long chain. And all fats have this structure. They're triacylglycerols. They're the most abundant dietary lipids in the form in which most of the carbon energy is stored. Each triacylglycerol, and you see here the diagram, has a backbone of glycerol. Glycerol being a sugar, being the alcohol of glucose. And each triacylglycerol has a glycerol backbone esterified to 3 fatty acids shown here. And these fatty acids can have different chain lengths. What is unique in terms of our fatty acids in terms of their chain length? Anybody tell me what is unique about the chain length? It's always a multiple of 2. And we'll get into that when we talk about fatty acid oxidation. But all of our fatty acids, our dietary fatty acids, have an even number of acyl side chains. Most of these triglycerides are mixed with different fatty acids varying in chain length and double bonds, unsaturated, saturated. We've already talked about that a bit. So most naturally occurring fatty acids have an even number, as I mentioned, of carbon atoms. And the pathway for catabolism of fatty acids Hello? Yeah, I'm in the middle of a lecture, Marcel. Be okay? Is this about her? Okay. I'll have to I'll try to figure it out, but I have to give this lecture and I'll call you back. Okay? Because are you going to be at the meeting at 2 o'clock? I'll call you before. Thanks. I had an interview this morning with an applicant to the medical school, and they didn't show up. That's what this is about. But their grandmother fell, and so all right. Anyway, so the pathway for catabolism of fatty acids is referred to as the beta oxidation pathway because oxidation occurs at the beta carbon, which is C minus 3. The carboxyl group is 1, and then 2 in is called the C3 or the beta carbon. The first step of beta oxidation is activation, and I'll show you all of these in individual diagram. Is activation of a fatty acid, the fatty acyl coenzyme A, in the cytosol by an enzyme on the outer mitochondrial membrane. Enzymes of the beta oxidation pathway are in the mitochondria. Everything takes place in the mitochondrial matrix. And how fatty acyl CoA formed in the cytosol is transported, well, it's transported with carnitine. And hence, that's why carnitine supplementation is always used, whether or not carnitine is normally recycled. But in patients with fatty acid oxidation, we tend to give carnitine problems. We tend to give carnitine to enhance transport across the mitochondrial membrane. Now, I'll show you that in greater detail. So this is the fatty acid oxidation pathway. And here we have the mitochondria to the left with the inner and the outer membrane. And I'm sorry, how fatty acids are transported. They transported across the membrane by carnitine, where they enter the beta oxidation cycle, which leads to oxidative phosphorylation and the synthesis in the liver of ketones. So we have long chain fatty acids. They then in the cytosol become fatty acyl coenzyme A. Then this fatty acyl coenzyme A, the CoA is cleaved off and recycled, and we get fatty acyl carnitine. Fatty acyl carnitine enters the mitochondria, where it is re-esterified to coenzyme A, keeping in mind that medium chain triglycerides don't require carnitine, they go right in, all right? And that becomes important when we discuss fatty acid oxidation disorders. And so then the fatty acyl CoA undergoes beta oxidation, and lo and behold, what do we get? We get acetyl CoA. And acetyl CoA, obviously, is the essential element leading to the production of ketones, which are used for energy. So the first step is activation, which allows the fatty acid in the cytosol to enter the mitochondria, and that combines the fatty acid with CoA, the fatty acyl CoA, and then we need ATP and fatty acyl CoA plus AMP plus 2-phosphate, and then carnitine right here in the inner membrane plus carnitine goes to fatty acyl carnitine. The fatty acyl carnitine transports the fatty acid into the matrix of the mitochondria, where the whole process is reversed. Carnitine is recycled, and we again produce fatty acyl CoA. So it's CoA to carnitine back to CoA, and then we can undergo the process of beta oxidation. So the controversy is, why do you really need to give carnitine? It's because we recycle our carnitine. We don't just get rid of it. And that's why the use of carnitine in this disorder is sort of a no harm, no foul procedure, because we probably don't really need it because we recycle all of our carnitine. Once we get fatty acyl CoA, we then enter the process of beta oxidation, which removes hydrogen atoms from the alpha and beta position. Remember, here's the alpha. Actually, this is the carboxyl end. That doesn't count. We're going one in. That's the alpha, that's the beta, and we form a trans carbon bond here. It's a double bond, all right? And then we reduce FAD to FADH2. And this process just continues and continues and continues. In reaction 2, remember we've got this now, beta oxidation, we hydrate, which forms a hydroxyl group. So the double bond is cleaved and we get a hydroxyl group, we add H2O. This is called hydration. In reaction 3, we oxidize again, forms another keto group, and on and on and on and on and on. Ultimately, what gets cleaved off is acetyl-CoA each time. And then acetyl-CoA is cleaved by splitting the bond between the alpha and beta carbons to form a shortened fatty acyl-CoA. And then this is all repeated until basically the fatty acid is gone. So if we look at myristic acid, which is a C14 fatty acid, oxidation, hydration, oxidation, cleavage. And then each time we're producing acetyl-CoA. So we get 7 acetyl-CoAs produced out of this beta oxidation of mysteric acid. And the activation, remember way back it required ATP, but one cycle of oxidation of a fatty acid produces 1 ADDH, which yields 3 ATP, 1 FADH2, which produces 2 ATP, and acetyl-CoA then can enter the citric acid cycle, which I'll show you in a minute, and 1 acetyl-CoA gives you 12 ATPs. This is why this is such a potent energy-producing process. So if we add it up all together, this is lauric acid C12. To activate lauric acid, it means to get it into the mitochondria, 2 ATP is required. Then we produce 6 acetyl-CoA, 72 ATP, and 5 oxidation cycles, another 25. So we get 95 molecules of ATP, all right? And this is actually 97, but we've used 2. So now, when you look at the acyl-CoA dehydrogenase, the enzymes that's responsible for all this, there are different enzymes that are responsible for the hydrolysis and dehydrogenation of specific chain lengths. So we have very long chain acyl-CoA dehydrogenase, that's 14 to 20 chain length, carbon length. Long chain acyl-CoA dehydrogenase 12 to 18, medium chain 6 to 12, and short chain less than 6. This becomes important when we try to identify specific fatty acid oxidation disorders. So again, fatty acids, CoA, you get an increase in fatty acyl-CoA, which undergoes beta oxidation, and then gives you acetyl-CoA and ketones. But what happens if you're unable to undergo beta oxidation? One of these enzymes, the acyl-CoA dehydrogenase, is absent, and you can't undergo beta oxidation. Well, then you get reduced acetyl-CoA, reduced ketones, and what are you starving for? You're starving for ATP. So what ends up happening? This is the typical tricarboxylic acid or a Krebs cycle. And as you can see, acetyl-CoA enters the Krebs cycle and the ultimate production is glucose. Now, where does most of this acetyl-CoA come from? Well, under normal conditions, most of this acetyl-CoA comes from fatty acids. But what happens when you have a problem with fatty acid oxidation? Your body needs glucose. How's it going to get it? Well, it gets it from breaking down protein, and these are their gluconeogenic amino acids. Well, when you start to break down protein, what do you produce a lot of?
Nitrogen wastes, like your
nitrogen waste. What is nitrogen waste form in the form of?
Initially, I think urea, and then it could be uric acid.
And
on animal it's in.
And ammonia, uric acid and ammonia. So again, this is again a marker for someone who's got a fatty acid oxidation disorder. They may develop hyperammonemia because they're breaking down all of this protein because they can't break down fat. The body needs glucose. How's the body going to get it? Can only get it from breaking down protein. So if we look at the pathophysiology of the acyl-CoA dehydrogenase, the fatty acid oxidation disorders, there are a number of problems which lead to toxicity. So there's low available of substrates, low available of energy, leading directly to cell damage. Again, hyperammonemia leads to cell damage. And you have all of this fatty acyl-CoA running around, and that is toxic to cells as well. So this fatty acyl-CoA, if not metabolized, present an oxidative stress, lead to mitochondrial dysfunction and cell damage. So when eating well and while otherwise healthy, patients may show no symptoms. Why not?
Because they're not doing much fat metabolism.
They're not engaging in fat. They're not engaged. If you're otherwise healthy, when do you use fat? Well, the healthy individual uses fat under stress and under fasting conditions. So if you're not under stress and you're not under prolonged fasting conditions, you're not going to have clinical symptoms. However, when food intake is inadequate or the patient is sick and the food intake can't keep up with demand, that's when symptoms develop. Nausea and vomiting, CNS problems, hepatic problems, muscle and heart dysfunction, not necessarily hypoglycemia. Hypoglycemia, again, is the inability to maintain a serum glucose level which is in the normal range. Well, you can do that for a certain amount of time, but when everything starts to be exhausted, that's when you develop hypoglycemia, or when you have some glucose produced, but because of stress, it's not enough. Fatty acid oxidation disorders are disorders of energy metabolism in which the brain and the body run out of energy, and glucose stores are exhausted. Ketone production is diminished. Remember, ketones are produced in the mitochondria through this process of activation, oxidation, hydration, oxidation, hydration, and cleavage. And when that doesn't happen, you don't get ketones. And what you do get is intermediate metabolites that I showed you on the earlier slides. These are toxic to the CNS. They also have an osmotic effect, causing brain swelling and leading to coma. The low concentrations of coenzyme A and the accumulation of fatty acyl-CoA molecules interfere with normal energy production in the Krebs cycle. So again, these fatty acyl-CoA molecules, which are running around and can't be processed, are directly toxic to the tricarboxylic acid cycle. And inadequate amounts of acetyl-CoA impair gluconeogenesis. Remember, I showed you on that slide, you got to get acetyl-CoA in order to produce glucose. And so you have impaired gluconeogenesis. So the cornerstone of therapy for these patients is fasting avoidance. Under normal conditions, you don't really need to restrict fat because fat synthesis is not impaired. So you may not be able to utilize that fat, but you're not going to call for it unless you're stressed or under fasting conditions. If you rely on glucose and avoid relying on fat, symptoms are minimized. The exception is in long-chain fatty acid oxidation. Remember that the heart muscle and the skeletal muscle both depend on glucose and fat. So when you get the long-chain or very long-chain disorders, you're really not able to metabolize much fat at all, and that becomes a problem in those disorders. When sick, energy demands rise and food intake diminishes. The body will use dietary fat to make ketones. When dietary fat is not available, you use endogenous fat. So the diet during times of illness should be high in carbohydrate and low in fat. That's probably good for a wise idea for any normal individual anyway, but especially in these patients. Fat restriction is not so important when the patient is otherwise healthy. So, medium chain triglycerides. Remember that medium chain do not require carnitine to be transported into the liver. Just like they don't require mixed micelles to be transported into the circulation from the intestine, they don't require carnitine be transported in the liver. They do not require oxidation by those enzymes that break down long-chain fat. Medium chain triglycerides bypass these enzymes and are broken down to form ketones using other working enzymes. So a patient with a long-chain fatty acid disorder, theoretically, and we'll talk about it, can be managed with medium chain triglycerides, limiting long-chain triglycerides, and they can be symptomatically perfectly normal because the enzymes involved in the beta oxidation of MCT are maintained. And this is very important for the management of long-chain fatty acid defects. And how many carbon atoms? 1, 2, 3, 4, 5, 6, 7. All right? So this is something called triheptanoin. Remember that medium chain fatty acids are chain length 6 to 12. This is triheptanoin, which is a synthetic fatty acid, a medium chain triglyceride. And so you have triheptanoin, okay, gives you a C7 fatty acid. Remember, you use the medium chain fatty acid oxidation enzymes transported right into the mitochondria. You don't require carnitine. And here you go into the tricarboxylic acid or Krebs cycle. This is in the patient who's got a long chain fatty acid oxidation disorder, this case, very long chain. Remember fatty acyl CoA, and we can't metabolize it. We're building this up. We're building this up. This is bad. So the way to avoid all of this problem is to go to something like triheptanoin, which bypasses everything, goes right into energy production. So here's a case for you. TR was born following a normal pregnancy, labor, and delivery, developed hypoglycemia on day 2 with associated lethargy and mottling. At 4 months, had feeding difficulties. At 5 months, became irritable and less responsive and had staring spells. What's happening at 4 and 5 months?
Well, the feeding difficulties could be associated with their heart failure that he develops later.
Why all of a sudden at 4 or 5 months? Why not 1 month?
I'm not sure.
Think about it. Anybody have babies around here? Aside from me and Dr. Wallach?
Yes.
What starts happening around 4, 5, 6 months?
What's the feeding schedule? Does it change or not?
Weaning?
They start to sleep longer at night.
Oh, yeah.
It's a fasting. They're fasting. All right? Remember, we all fast during the day. Most of us fast at night. All right? We're all fasting. So this is what happens. This is very typical. And examination revealed a gallop and a murmur, and the testing revealed cardiomyopathy and heart failure. So this is something that's going on for a long time, but really became symptomatic as a result of prolonged fasting at night. So standard laboratory tests were done. They're shown here. This is what you're going to get in everyone. and I'll show you how to interpret them in following slides. And so this is what happened. White cell count was 25,000. The sodium is 133, potassium 5.8, creatinine kinase 224,000, lactate dehydrogenase 10,000, alanine transferase 900, and negative for ketones. Somebody want to interpret these and tell me what's going on? Come on, guys. This is pediatrics. This is not pediatric GI.
Sepsis?
Take a stab at it.
Dr. Risby had an answer.
Okay. White cell count is 25,000. What does that tell you?
It's high.
What?
It's high.
It tells you stress.
Yes.
All right? It tells you stress. Doesn't tell you why. It tells you stress. What's the sodium of 133 and the potassium of 5.8? Why is that? Why do you get that?
The sodium's on a little on the low side and the potassium's on the higher side.
Why is that?
Dehydration.
This is a result of cellular breakdown. You have all this potassium being released into the circulation because you're using cells for gluconeogenesis. The sodium goes down because you lose less sodium than you do potassium, but you're losing them both. All right? All right? You know, remember, most potassium is intracellular. So when you start seeing elevated potassium, you wonder, why is if it's not exogenously administered, it's coming from the intracellular space, from the cytosol. You're breaking down cells. Creatine kinase, 224,000. Why?
It's elevated.
Breakdown again, the muscle breakdown.
Yeah, you're breaking down protein. Lactate dehydrogenase, 10,000. Why? You're producing a hell of a lot of lactate because you're undergoing anaerobic glycolysis.
Right.
All right? And so lactate dehydrogenase is trying to keep up with metabolizing lactate. Lactate then becomes what? What does lactate get metabolized to?
Lactic acid?
Pyruvate.
Oh.
Alanine transferase, 900, obviously, because you break the alanine is a gluconeogenic amino acid. And urinalysis was negative for ketones. So if you see the urinalysis is negative for ketones, all of the rest falls into place.
Because we aren't making any ketones from the fat to use as energy production.
You're not making any ketones, all right? This is probably someone with a very long chain or long chain fatty acid oxidation disorder, not breaking down any fat. Within hours of admission, her muscle weakness worsened with the development of progressive respiratory paralysis and failure. Arterial blood gas measurement while the patient was on supplemental oxygen showed the following: had a respiratory acidosis and hypercapnia. pH was 7.28. Carbon dioxide arterial tension was 15 with a negative base excess. So all of this is happening. This is what you need to know. All right? So this is somebody who presents with a metabolic acidosis and an anion gap. Dr. Rabinowitz's favorite diagram. All right? The first thing we do is we look at whether the lactate is normal or elevated. Remember, in this case, we've got a really elevated lactate dehydrogenase. So that's keeping up. The lactate is normal. Then we can look at organic acids. All right? And if the patient has abnormal organic acids, they're organic acidemia. But what about if they have elevated lactate? Well, in this case, we see an elevated lactate dehydrogenase. The patient may or may not have an elevated lactate. My presumption is probably. So if you have an elevated lactate, all right, and I'm presuming you do because the lactate dehydrogenase is so elevated, it can only be elevated if you have increased lactate production. So elevated lactate, if you have, in this case, you're also going to have abnormal organic acids. The difference between the organic acidemias and the fatty acid oxidation disorders is that in one case you have abnormal organic acids with an elevated lactate, in the other case you have a normal lactate. All right? Then you have abnormal organic acids, and those can be methylmalonic acidemia, propionic acidemia, because remember, you're breaking down all of these proteins that are producing these abnormal organic acids. That leads to dicarboxylic aciduria, and once you get that, you know you have a fatty acid oxidation defect. All right. So this is the laboratory way, aside from doing GCMS or HPLC, to make this diagnosis. Simply by looking at organic acids, dicarboxylic acids, and lactate. So metabolic testing revealed a diagnosis of very long-chain acyl-CoA dehydrogenase deficiency, and the enzyme testing confirmed the diagnosis. So this patient was put on a diet of 30 to 35% calories from fat, 75% of fat, I showed you earlier, triheptanoic acid, 15% of fat from medium chain triglycerides, other than triheptanoic acid, and 10% of fat from long chain triglycerides. Carnitine was given to maintain normal levels. Remember, I said it may or may not be required, but it's safe to give it. And nighttime feeds, of course, the patient then had nasogastric feeds, ended at 30 months, and then cornstarch was given with triheptanone and MCT during the day. Why cornstarch?
It's a complex carbohydrate, so it'll
Carbohydrate, it's very, very slowly absorbed, so you don't get wide swings in your insulin. Heart size normalized over 24 months. Ventricular hypertrophy resolved by 4 years. And intercurrent illnesses were associated with elevated LFTs and creatine phosphokinase and resolved with intravenous fluids. Obviously, intravenous fluids containing glucose prevented the breakdown of protein for gluconeogenesis. So TR continued to avoid prolonged fasting and watched her fat intake, but stopped taking daily MCT supplements. Complained of muscle cramping after exercising, increased muscle fatigue, jaw cramping in the morning, and her CPK levels were elevated. Once MCT supplementation was restarted, everything normalized. So again, this was a patient who's relatively easily managed. So, fasting avoidance is the cornerstone of therapy. Fat restriction under normal circumstances is not really required. And in long-chain fatty acid oxidation disorders, medium-chain fatty acid supplementation is required. And again, the role of carnitine is somewhat controversial, but clearly is used in these cases to avoid potential carnitine deficiency. Carnitine, remember, binds to the fatty acid oxidation intermediate molecules, facilitates their excretion. Again, its benefit during periods of health are unclear. Often levels are normal at these times. If there are any deficiencies, these should be corrected. The role of carnitine, the benefit of it is more obvious when the patient is sick and you're really trying to cycle a lot of fatty acid for beta oxidation into the mitochondria. What about glucose monitoring? So Keep in mind that lethargy and coma can occur in the absence of a low blood sugar. Therefore, if the patient is not hypoglycemic, glucometer readings may offer a false sense of security. And if the patient has symptoms, whether or not they're hypoglycemic, they should be managed as if they are in this particular group of disorders. So, when patients are sick, we typically give 10% dextrose at 1.25 times maintenance. Does anybody know why? Well, since there's no answer. Dennis Beer, who I knew years ago, in 1977 was the one who figured this all out. Dr. Beer was an OB/GYN doctor. Why 10% dextrose when sick? Glycogen breakdown and gluconeogenesis and fatty acid oxidation occur when the amount of dietary or IV glucose falls below the basal glucose production rate in the liver. And Dr. Beer determined in 1977 that this rate of glucose production equals Y, and here's the equation, where Y equals the glucose production rate and X equals body weight. So the basal glucose production rate, according to this formula, was about 75 milligrams per minute of glucose, or 7.5 milligrams per kilogram per minute. 10% dextrose at maintenance provides 70 milligrams per minute, or 7 milligrams per kilogram per minute, just below the basal glucose production rate. 10% dextrose at 1.25 maintenance provides 87 milligrams per minute, or 8.7 milligrams per kilogram per minute. You're never going to see this on the boards, but this is why we give 10% dextrose. It's not because somebody pulled it out of the air. It's because this is based on a calculation of our basal glucose production and trying to provide slightly more glucose than is represented by basal glucose production. A couple of things you have to know, of course, is the issues of HELP syndrome and acute fatty liver or pregnancy. HELP syndrome being hemolysis, elevated LFTs, and low platelets. This is when you have, remember, this is an autosomal recessive disorder. So you have a haploinsufficient mother and an affected fetus. The affected fetus has defective beta oxidation, as does the placenta, presents the haploinsufficient mother with this barrage of long-chain fatty acids and acylcarnitines that exceed the haploinsufficient mother for metabolize or ability to metabolize. So the transfer of long-chain fatty acids and acylcarnitines from the affected fetus and placenta to the haploinsufficient mother causes liver disease during pregnancy. And that leads to HELP syndrome and acute fatty liver pregnancy. So it's all based on the excess amount of acylcarnitines and long-chain fatty acids passing through the placenta and fetus, both of which manifest defective beta oxidation, and the mother's metabolism, because she is haploinsufficient, is incapable of keeping up with the load. So now we're going to turn to medium chain disorders. What is MCHAD? How does it present? How is it diagnosed? How is it treated? And what is the prognosis? Previously, we've done with long chain. What do we do with medium chain? So this is medium chain acyl-CoA dehydrogenase deficiency, which causes a block in the oxidation of fatty acids. Remember, you can have long chain or very long chain fatty acids. They can be metabolized up till you get to the medium chain point, and then it stops. And so fatty acid, keep in mind that fatty acid oxidation is the repeated sequence of reactions shortening the fatty acid carbon chain by 2 carbon atoms for each cycle to produce energy. So in MCHAD, you have a deficiency of the medium chain length acyl-CoA dehydrogenase, and you get an accumulation of medium chain fatty acids and metabolites, and you have impaired ketone production, not absent ketone production, because remember, most of our dietary fat is long chain and very long chain. So you're able to metabolize those fatty acids up to a point. So these patients are not going to be necessarily hypoketotic because they are able to produce ketones. It's autosomal recessive on chromosome 1. Its carrier rate is 1 in 50 in the United Kingdom, and it's a specific mutation. Yes, you don't have to know about. And it presents exactly like you would expect it to present, and these patients have hypoketotic hypoglycemia. So that's the biochemical hallmark. They have ketones, they're just lower, not absent. And one of my former colleagues at Children's Hospital of Philadelphia, Charlie Stanley, looked at these patients. And here we have free fatty acids in yellow, ketones in green, glucose in red. And here you can see this is a patient with MCHAD deficiency. Sorry. And as you can see, the glucose remains pretty stable at, somewhat hypoglycemic, right? Free fatty acids go way elevated. Now, when free fatty acids go up like this, you assume they can't be metabolized at all, and you would have absent ketones. But in this case, you don't have absent ketones. They're just low. And here is GCMS. This is normal versus MCHAD deficiency. And what you get is you get an elevation of medium acylcarnitines. Remember here, they're absent under normal conditions, all right? Here, in MCHAD deficiency, the C16 is normal, but the C8, I'm sorry, in MCHAD deficiency, you have a marked elevation in C8 carnitine. So again, this is just screening. We don't have to go. The U.S. screening incidence of this is about 1 in 15,000. And again, they develop the kind of thing that you would expect with mitochondrial dysfunction. These are much more difficult to manage because, again, whatever dietary fat you give, you're going to reach a point where you can't metabolize it. So there's a very high rate of mortality and a very high rate of CNS sequelae in these patients. And again, the biochemical hallmark is hypoketotic hypoglycemia. So how do you manage them? Well, presentation usually follows an excessive period of fasting and increased energy requirement. These are patients you really do need to keep on a high carbohydrate diet and possibly with fat restriction. Again, because you can't replace fat with anything that is lipid based because of the problem with you reach a stop point in metabolism. And as you, again here, these are just the symptoms. Again, that's a real crossover between the symptoms of MCHAD and LCHAD. I've never seen a patient with MCHAD deficiency. I have seen patients with long chain acylcarnitine deficiency. And again, long-term sequelae are shown here, primarily neurologic, as you would expect. Avoid fasting, high calorie supplementation, use of IV dextrose. Again, the management of these groups of disorders are very similar. It's just that this one is much more severe. So to summarize, the fatty acid oxidation disorders are shown in this slide. We see the general manifestations to the left, the specific manifestations, which I've shown here. You can look this up. Each of these have specific phenotypic problems. Remember, importantly for the boards, that when you get HELP syndrome or acute fatty liver pregnancy, this is the MCHAD deficiency group. This is the one group you really should read the most about, because if any of these disorders is going to be on the boards, it's going to be the MCHAD deficiency. And in all cases, avoid fasting and avoid conditions that favor fat mobilization. And that is it.
What's nice for me is I get to add a second thing to the list of conditions I've seen that Steve hasn't. So I got cloacal polyps and now MCHAD.
Well, again, for the fellows, you've got to read this stuff up. I mean, it's, you know, you're not going to remember it unless you read it.
I agree, but I also think it's important to not just read and try to get those memory associations, but if you get the basics of fat metabolism,
Well, that's what I mean.
you can really extrapolate a lot of some of the second. Now, there's some things like HELP syndrome or the pregnancy thing, you just have to know that.
Yeah.
But you can at least identify that this is a fatty acid oxidation defect from the prompt without necessarily having all these things like memorized, because you'd be like, okay, what's the output? So it's just I like trying to remember the system in case I can't remember the specific, because there's less systems than there are specifics.
Okay. Very good. Monday
will not be having passed
Monday we'll do
because it's selected.
mitochondrial hepatopathies.
All right, sounds good.
All right.
I'm going to be sending out a poll shortly for Steve's gala. We're finding a time in June or July so that his family can come in.
Yeah, my daughter is going to be here from June 22nd to July 29th.
And we're going to throw a fun party.
Yeah, right.
So hopefully everyone can make it for that, because I think it'll be a good time. We're also going to be fundraising for our research grant system and everything else like that we're trying to set up. So it's two things. We're gonna have a nice time and celebrate Steve, and then we're gonna hassle all Steve's friends for money. Sorry.
Get some money, we hope.
Huh?
Get some money.
Yeah, well, we're at least gonna bother him for it.
I guess I'll have to contribute.
I mean, I think it's. I don't know what the form is for contributing to something in your name. I feel like if you donated the money to endow it, yes, but like
I would not do it.
Yeah, I wouldn't worry too much about it. But yeah, we're gonna throw a party for that. Other announcements: Daniel has officially started across the street. We are still working out the details for getting him onboarded for the call rotation, so that will not shift as of now. I sent you guys all the updated call. I'll send it out to the fellows. I apologize, guys. I've been overwhelmed and didn't get it to you.
So your new person is at Kings County?
Yes.
And he's by himself?
Yeah, but I mean, he's going to be part of our group.
But what happens in an emergency now?
He will be, that's what we're working out, which is the hospital being annoying, but is agreeing with us finally, getting him privileged at downstate so he covers both sides. The rate limiting step was that they were unwilling to cover his malpractice if they don't pay him. Which I was like, that's weird, because we can show you the math that he's worth more to you than the malpractice costs. And they were like, no, we have to pay him. So they have to like work out some sort of thing where he gets, Kings County is going to pay them like $2,000 and they're going to pay him $2,000, and that will be the end of that. But it's annoying. Once that gets resolved, he'll be onboarded. They have finally approved the posting for our new NP. So I'm hoping we have that person join us by the end of the year. Let's see, there was something else I wanted to bring up. Next week we have on Monday, Dr. Bastardi and I will be doing a talk about atopy, more targeted at general pediatricians, but if anybody wants a free dinner Monday night, please feel free to RSVP and join us at Sundays in Brooklyn. I'll send out the link. And then Wednesday, we're going to be up in Harlem at Red Rooster for the Gut Club, which will be speakers from Mount Sinai about aerodigestive, which I think will be really useful for you guys, because we don't have part of the tools that we need for that here. Simon does a great job and making do with what we have, but like a fully multidisciplinary clinic would have a few more people. And then the speaker will be a fellow from Columbia talking about health, socioeconomic and need screening in clinic with some ideas I think we might be able to actually deploy here, and potentially figure out some things that can help our patients, or at least avoid some of the common pitfalls we run into. That was all my things.
Tom, I need to speak to you on a personal issue.
Sure. You want to call me or just stay on the line?
No, I'll stay on with you.
Okay.
All right.
And then I was trying to think of anything else I should tell everybody.
Dr. Wallach, for the in-service training, I have sent my credentials to Greta. I think Bryce and I are
She's
still
out
not
with some personal
registered.
stuff, and unfortunately, I don't know how to fix that. I can try calling them with you myself.
You can register for the site exam completely on your own, but
Yeah, I thought that was the case. I didn't understand what the problem was.
Oh, it's like, I think it's $110 or something like that, and I think Greta uses her card to pay for it. So she does it on her own.
Oh, if that's the rate limiting step, let's just do it and I'll pay you back. Either Greta will pay you back or I'll pay you back.
I also went with that route because she didn't have any availability when I could meet with her. So.
It's fine. Well, we just make sure we can either get you reimbursed.
Bryce, because she said that you're not registered, so I don't know if there's a specific
I'm
code that we need to put for downstate that she knows only to be able to take it at
I
downstate.
went to my ABP website and it said apply for an exam, and it had the site listed. I clicked it. I paid. I got a letter from them saying that I paid and that my application was submitted. So I don't.
Because she said that you're not registered.
Go ahead.
She said that you're not registered. Is why I'm thinking that it might be downstate specific.
Because I did it this morning after I saw an email, so maybe that was what was.
Oh, okay.
I'm pretty sure you registered for it on your own. But I also know that the programs can also do it for you. I'll just email Greta and see if there's someone else who can help, given that this is being annoying.
I gave her my login credentials. If she's unable to do it by closer to the deadline, then I'll just go ahead and do it myself.
We'll reimburse you. It's not, I wouldn't worry too much about it. Because she's just challenging for these things.
Sounds good. All right. Thank you.
All right.
All right.
Bye.
Tom, stay on.
Yep.
And just to
No
confirm,
paths
there
today?
is no pathology today?
No, they didn't get the slides.
Okay, all right, thank you.
Yeah, no,
The
Okay,
key
thank you.
point is that when did you request the slides, Mariam?
Monday.
When did you officially request them to be sent over to Maimonides? When?
Monday. This Monday.
Yeah, it needs to be done Friday. And then you need to follow up like many things at downstate.
Okay, I'll do that next time. Thank you.
Thank you.
Bryce, sign off, please. Bryce, sign off, please.
See if I can control participants. Move.
Oh,
I can't.
You know about Mel?
No.
They found an 8-centimeter tumor on his kidney. He's having an nephrectomy tomorrow. They think it's, I spoke to him. They think it's stage 1B renal cell carcinoma. But I told him I might be in a benign oncocytoma with that size. So I spoke to him a couple of days ago. Just wanted to let you know. He's having it tomorrow.
I don't know enough about these tumors. Did they already do the
It's very large, which makes me, and it was found incidentally.
Yeah.
So because it's that size and found incidentally, my suspicion is it's not a carcinoma. My suspicion is it's an oncocytoma.
Even if it is a carcinoma, if it's not metastatic,
It's not metastatic. They're doing a total nephrectomy.
But again, like even if it's an RCC,
He's
if
not
it's
going
not
to need
metastatic,
chemotherapy. He's not going to need chemo or
no,
radiation.
it's basically just the risk of the surgery at that
Yeah.
point. Given, I can't imagine there's the 5-year survival for isolated looks like it's like above 90.
Yeah, what he said to me, they couldn't do what they did on me, which is they did a partial nephrectomy because mine was really small.
Yeah.
It's wrapping around the renal vein, so they got to take out that.
Well, I mean, it means to get good margins, and you don't need 2 kidneys.
Yeah, yeah. So I just wanted to let you know.
Since she was 2.
Yeah.
Did I ever tell you this story? It's a funny story.
What?
My mom grew up in a foreign service family, so she was born in Thailand, and when she was 2, they lived in India. And my grandmother felt a mass on her lower left side. Went to the hospital, and they were like, "Well, yeah, we got to do some stuff." And they thought, "Okay, we don't know exactly what this is." They didn't have all the imaging and stuff then, but clearly you need surgery. The best surgeon in town, I think they were in Hyderabad, is a Scottish guy, but the Scottish guy has the very common British tradition of a liquid lunch, and is just wasted by after lunch. It's like a 5 to 6 martini kind of lunch. And so everyone's like, this is the guy, you want this guy.
In the morning.
And so they wait for 3 weeks with this giant tumor to get this guy. Luckily it's a Wilms tumor and not a bad one, and she does fine. But like that whole story is just like insane. Like both being the early 50s and being in India is just like, that's such a alien ballpark to me. And to have it go so smoothly, she has like no side effects from it at all.
Crazy. All right, well, just
that's terrible to hear, but not as bad as I was first thinking. But still really unfortunate. Should I reach out? Is he okay hearing from people?
I would reach out in a couple of days. Just send, that I told you. Just want to make sure everything's okay.
Yeah. No, I mean, we're close. I'm sure. I don't think Jody or Mel would mind, but that's just
yeah.
Well, that sucks. I was hoping to see him at Crohn's and colitis, but it seems like I will not.
Yeah. All right. Just want to let you know. All right.
Thanks, Steve.
Yeah.